From the Heart.org Medscape Cardiology, this is the Bob Harrington Show. Dr. Robert Harrington is the Arthur L. Bloomfield Professor and Chair of Medicine at Stanford University.
Hi, this is Bob Harrington from Stanford University here on Medscape Cardiology and the Heart.org. At the end of the year in 2018, Mike Gibson and I did a podcast where we reviewed sort of the big developments of 2018 in cardiology. And then we did a second podcast where we looked forward in 2019 to what we were expecting. Now, it was pointed out to Mike and I, because both of us are interventional cardiologists, that we talked a lot about ischemic heart disease, we talked a lot about interventional cardiology, then we talked about some new technologies like digital and artificial intelligence, but we were a little thin on our coverage of heart failure. And I think that criticism was warranted, because this is one of the most important diseases, syndromes, and set of patients that all of us who practice cardiology are faced with. And so understanding some of the new thinking, some of the observations that were made in 2018, and maybe more importantly, some of the things that are being done to help us understand the heart failure patient, to help us understand some of the mechanisms of the development of heart failure, and then most of all, to help us understand potentially therapies that might be of benefit to these patients is critically important. So I'm both thankful for his criticism as well as thankful for him joining us today to discuss heart failure is my good friend and colleague, Clyde Yancy from Northwestern University. Clyde is a professor of medicine and the chief of the Division of Cardiovascular Medicine at Northwestern University Feinberg School of Medicine, where he also serves as the Vice Dean of Diversity. Clyde, thank you very much for joining us today on Medscape Cardiology.
Bob, I'm really delighted to be a part of this conversation and delighted to work with you and your colleagues at Medscape Cardiology. And even though my first outreach to you was almost tongue-in-cheek, I really was insistent on having an opportunity to express the heart failure voice, not because we think there should be fair billing, but there's really something to say. And as we are in 2019 now, and we think about the aggregate data that have come forward since 2018 and what we expect in 2019, there's reason for a lot of excitement in heart failure. I've even recently recorded a piece that, maybe heart failure is becoming sexy. Play on words, obviously, but it is, in fact, intriguing and interesting, and we want to help promulgate that message as much as we can. So thanks for this opportunity.
Well, you're the perfect person to do it, both given your clinical and research background, but also given your role in the development of the heart failure guidelines over the last few editions. Maybe, Clyde, we'll start with the overarching comments. Give us a sense of the burden of disease in U.S. society of patients with heart failure and their associated treatment.
So this actually is an excellent way to begin, because we have recited statistics for decades, and we keep saying 5 million people, et cetera, et cetera. But what we know now is that because of the aging of our population and recognizing that heart failure, for the most part, is a disease or a condition of becoming older, and because we're doing such a phenomenally better job with acute ischemic syndromes, valvular heart disease, now hypertension, we are realizing the successes we've achieved in other areas coming together to amplify this signal on heart failure. So we really do believe that by 2025 to 2030, that number of 5 or 6 million will be up to between 8 and 10 million. Now we're talking about a public health crisis and a huge consumption problem for our healthcare resources. And so it really does two things. It shifts our awareness to understand how do we get here, and the second thing is, can we do anything to prevent it?
Well, let's jump right into prevention, because I think, as you've indicated, we used to think that prevention of heart failure was really around dealing with atherosclerotic disease and the prevention of ischemic heart disease, which might lead to at least one syndrome of heart failure. But you've been pointing out lately that there are important issues around a heart-healthy lifestyle and the intersection of diabetes, obesity, and hypertension that are driving heart failure. So why don't you talk about some of the new developments in thinking about the prevention of heart failure?
So, Bob, this really is the real critical piece for us to highlight to everyone who's listening, because ostensibly we actually can prevent heart failure. Now, that has more heft to it than you think, because what we've known all along is that we don't have a cure for the condition when it occurs. We can improve outcomes for certain. But once it occurs, that really does fundamentally redefine the trajectory of life and living for the person affected. So getting to the patient before that negative inflection point happens on their life trajectory couldn't be more important. We've known since 1971, Bob, that there was an unbelievably tight alignment between a history of hypertension and the development of heart failure. Those data came from the seminal landscape observations in Framingham. They've been endorsed time and time and time again, but the really critical new piece of information really is a direct output from the SPRINT trial, demonstrating that in those that are at increased risk for cardiovascular disease, and you and I both know the risk calculators involved to assess that risk profile, if we target an out-of-clinic blood pressure of 120 over 80 or less, or an in-clinic blood pressure of 130 over 80, we were able to reduce the incidence of new-onset heart failure requiring hospitalization by nearly 40%. Bob, in my mind, that's a huge pause moment, because there is something fundamental about becoming so sick from heart failure that you require hospitalization. It changes everything. Getting there early, nothing can be more important. And then we further backfill this imperative to get there early, start disease-modifying drugs, lowering blood pressure as appropriate. We now have an unbelievably growing data set that says biomarker screening can help us better discriminate whom it is that might benefit from a more aggressive assessment of ventricular function and early initiation of therapy. So there's much excitement about this opportunity to prevent heart failure. And Bob, that's just focusing on hypertension.
Yeah, and the hypertension data, I agree with you. The SPRINT data are very compelling, that there are many reasons to be more aggressive in our treatment of blood pressure. But it is interesting when you talk to patients, walking them through the things that you can prevent by better treatment of their hypertension. Heart failure really resonates with patients, doesn't it?
Oh, absolutely, because you know what? Since 1 in 5 Americans, think about this, 1 in 5 Americans will get heart failure during their lifetime. This is not a disease about them, it's a disease about us. So everyone knows someone, has a family member. Physicians have been consulted formally, informally about this condition. So it really does reflect an everyday book of knowledge that we need to possess. But it goes to the next level, because remember that the important new guidelines on hypertension articulate that lifestyle adjustment is the first, second, and third step unless blood pressure is extremely elevated. Intersects so well with what we're talking about with regards to heart failure, because as you highlighted, Life Simple 7 that has been extant since 2010 now has a fairly good data set to indicate that people who incorporate those 7 attributes into their daily life and living, again, have a dramatically reduced likelihood of having heart failure. And then if we extend this over to diabetes and understand that we have new therapies that are consistently showing a signal not of cardiovascular harm, not even cardiovascular neutrality, which we were willing to accept just a few years ago, but cardiovascular benefit, the benefit being defined as a reduction in the incidence of heart failure. You've got 3 powerful switches you can pull now to reduce the incidence to prevent heart failure. Adequate control of blood pressure, incorporation of lifestyle adjustment, and where diabetes is present, utilization of new therapies that have been consistently shown now to reduce this incidence. I really think that's cause for excitement to think that you can prevent someone from the consequences of heart failure. That's pretty important.
The data that you're indicating or alluding to with the SGLT2 inhibitors in diabetes, you could not be more right about this was not anticipated when the trials began. As you said, most of these big diabetes trials were looking to see if the new therapies, in fact, did not cause cardiac harm. But this finding on the reduction of heart failure emerged, as you said, very consistently across the data sets. To me, this is the perfect example of clinical data then driving the bench scientists to go back and say, okay, here's this observation which appears real. Let's now search for mechanism to try to understand it, so then we can pursue even new directions to help our patients.
It was so fun when we first saw these data, because as you and I look at these data, my lens, thinking about heart failure, is like, eureka, we have another tool in the tool chest. And your lens as a clinical trialist is like, huh? Well, we need to figure this out. But it came together so that we now have 3 different data sets in the same drug class, 3 different data sets that say the signal is real and it's worth our attention.
I want to touch both on treatment of the reduced ejection fraction patient and treatment of the preserved ejection fraction patient, not broadly, but hitting a couple of key issues in each, because what I really want to do is spend some time on this emerging concept of mid-range ejection fraction. Let's do reduced ejection fraction first, Clyde. Boy, a lot of evidence over the last year that just doing simple things like adhering to what we know works, so-called guideline-directed medical therapy, is still pretty valuable, isn't it?
Yeah, so let me show you the goalposts in this discussion, because this really is another seminal piece of information for our listeners to capture. We know that when best practices are exercised, the outcomes can be better than we ever thought. That's really good news. But the other part of this goalpost, which is the opposite end of the spectrum, is very, very sobering information that despite the fact that we know what to do, we've got well-articulated guidelines supported by robust evidence, real-world application of these evidence-based strategies fails miserably, to the extent that in eligible patients, as derived from the recently released CHAMP-HF registry, in eligible patients for guideline-directed medical therapy, only 25% were on one of each of the three drug classes, a RAS inhibitor, an evidence-based beta blocker, and a mineralocorticoid antagonist. And Bob, the part that you always have to kind of sit down and catch your breath is when I tell you that only 1% were on a candidate drug from each drug class given at the doses prescribed in the clinical trials. That's an enormously big missed opportunity. And so if there's some themes that our listeners are walking away with, theme number one, heart failure can be prevented. There are ways we can target this. Number two, let's keep it simple. Let's just do the things we know will work to make a difference.
It's interesting, Clyde, as I talk to cardiology fellows and other young clinical scientists, I point out all the time that health services research, implementation science are really hot areas because of the data that you've just shared. We don't necessarily need everybody studying brand new therapies. We need some people who are very engaged with the tools of implementation science. Are you talking to your trainees about those topics?
Absolutely, so much so that we're training our trainees to take a deep dive into those topics. So we have young fellows that are focused on wearable technologies. We have young fellows that are becoming expert in, I won't say big data because that means too many different things, but in bioinformatics. We really are trying to understand how can we use data? How can we make it so that the electronic health systems that we all bemoan, and I'm in that line, actually can enable. So is there a way we can do this? Can we actually build crisp decision tools that will make it so much easier to screen patients, identify those that are candidates for evidence-based therapy, and introduce the right prompts to make all this happen? So yeah, we are fully invested because we realize that, maybe right now we don't need another major breakthrough at the bench. We need a breakthrough at the pill bottle. And if we can make that happen, it could be a big difference.
Yeah, I completely agree with you. Let's quickly do a nod to our interventional colleagues. Treatment of mitral regurgitation and treatment of AFib, potentially really big findings over the past year to aid in the reduced ejection fraction population.
Well, I knew the world was beginning to spin differently when all of a sudden the interventional world was inviting me to their meetings and wanting commentary about heart failure. I said, whoa, stop the presses. Something just happened here. But it's precisely because these new interventions that really appear to be quite impactful are selectively improving the trajectory of those with heart failure. Thinking about the reapposition of mitral valve leaflets in a setting of severe MR that goes beyond that which seems appropriate. And we're talking now about functional MR and being able to fundamentally improve outcomes. That's great information. I mean, I think the COAP data need to be celebrated as a major contribution. And then getting back to implementation, how do we go beyond that group of really skilled clinical trialists who perform COAP and make it broadly available to the community for the right patient, and then identifying the right patient, given that there are data in contradistinction from MITRA-FR in the European space, but that's more of a tangent. Then we think about atrial fibrillation. Bob, we're still trying to wrestle with this. We know that the concurrent presence of atrial fibrillation and heart failure is, as we used to say back in the Deep South, badness. We know that.
Yeah.
But when we think about how can we modify that pairing and improve outcomes, ablation makes sense. But before ablation, it was really about rate control in the setting of atrial fibrillation, less so than rhythm control. We have two signals, and I'll emphasize signals now, that maybe ablation might be beneficial in the setting of heart failure when atrial fibrillation is present. I'm on the AFib guideline writing committee, and we wrestled with the data set, and we came back with the best response we could. It's a class of recommendation 2B, and you and I both know what that means. But it means highly selected, uncertain of the real benefit, but it's something that goes into your decision tree. We'd like to see that signal become more crisp. I am reassured that from the Cabana trial, the quality of life data led by your former colleague and my friend Dan Mark show the quality of life really does improve after ablation for atrial fibrillation. I think that's smart because that's really why we send patients for ablation. Patients want to feel better. So let's say, call it a day, we can help patients feel better. So those are two device things that intersect.
So I think that's really important that we're starting to bring together disciplines outside of what I'll call
Yes.
the traditional group who took care of the heart failure patient.
It's excellent because what that means is that everybody's got to get involved in screening for heart failure now, and that can only be for the good. And that means we'll have to build different systems of care, different referral patterns, but that's all for the good. I look at what's happened with aortic stenosis. It's not a quiet diagnosis anymore. Everybody has their antenna raised, and it's helping patients. And so hopefully we can do the same thing. You made an important statement about HFpEF, and I don't want to miss the opportunity to let all the listeners know that 2019 is a big year for heart failure with preserved ejection fraction. The investigators involved in Paragon-HF, which is testing the ARNI compound, the neprilysin inhibitor with valsartan, in the setting of HFpEF, will come out probably in the second half of the year, maybe coincident with ESC, maybe coincident with our meeting, American Heart Association meeting in November. But boy, no matter what the results are, they will make a difference. If it is yet another negative trial, it really will tell us, hit the kill switch. We have to completely start over and further dissect this condition into its component parts. If there is a hint, if there is a signal, and especially if it's positive, that really will be a moment for us to celebrate, much like we've celebrated with some of the recent trials, because it will have direct clinical application. And so that's really important.
For HFpEF, I've been really impressed by the work of your colleague, Sanjeev Shah, in his making a compelling case that HFpEF is not a disease, but is multiple diseases or multiple syndromes. And I look forward to seeing more and more of that work, because my guess is that as we think about precision-based medicine, we're going to see diseases reclassified, we're going to see diseases recategorized, and then we're going to look for therapies within those categorizations. And I'm very excited by that work.
So I would agree with you and then take it to the next level, because you and I both are in situations where we train medical students, residents, and fellows. And what a beautiful model to share with others, to say here is a physician that we've been able to shepherd through all of these phases and look at the extraordinary contributions, whether it's phenol mapping and HFpEF, whether it's creating an interatrial shunt for those that have HFpEF with pulmonary hypertension, whether it's dealing with infiltrative diseases like amyloid cardiomyopathies. It's just stunning for someone that still has a teacher's DNA somewhere buried inside of me
Yes.
to see a student, now a mature faculty member, really emerge owning so much of one particular space. I mean, that may come into work worthwhile.
Yeah, absolutely. A lot of lessons there. As we close, Clyde, let's do the mid-range ejection fraction, because until I started hearing you at some of the meetings, I was not even aware of the phrase heart failure with mid-range ejection fraction. You want to first describe it for the audience? Tell us what's hot in this area and what they might expect in 2019, and then we'll wrap it up.
Yeah, absolutely. And I want to start by saying heart failure with mid-range ejection fraction, that is an ejection fraction greater than 40 but less than 50, it's not just a quirk of having one eye open and one eye closed in the echo lab. There is something unique about being in that mid-range, particularly when the path the patient has followed to get into that mid-range started off with heart failure with reduced ejection fraction. That's what has so many of us enthused, because what is it that's happening in about 15% of the patients that have reduced EF heart failure that allows them to respond so robustly to evidence-based therapy and end up with a residual ejection fraction greater than 40%. And as you point out, thinking about outcome sciences, the entire consistency of the signal demonstrates that when that event occurs, the outcomes are better. Fewer hospitalizations, better survival. And so you think, we want to enable that, right? And so it's been a great opportunity for us to understand who might those patients be, can we identify it a priori, but as we get excited about the science, as we discriminate that there is this new phenotype, we have a major reason to be careful, because we know that every clinician, everybody has seen that one case, that two case, in my practice, lots of cases, where people get better. Do you just kind of say, wow, we dodged this, it's a great thing? Or what happens when the patient says, okay, I feel better, and you tell me the numbers are better, do I have to take all this medicine? And then you kind of have this blank stare. So we have the data now from TREAD-HF, and we really helped in the orchestration of that study and helped in the messaging when the study came out in the Lancet. And what was really important was to demonstrate that even in those people where there was overwhelming evidence that they truly were better, and realize that I'm careful with my words. I'm not saying had recovered, but they were better once the medicines were systematically withdrawn by protocol. Within 8 weeks, over 40% had recrudescent heart failure. So the word is not recovered. The word is remission, akin to the cancer parallels, but that's okay because the outcomes are so much better and the patients are better. So we're excited about this because we want to know, how do you go from being low to mid-range? Can we manipulate this? Can we reaffirm that the patient will do better, but can we also understand what's the least burdensome medical profile that we need to maintain so that the patient is less encumbered but still has the benefit of having been improved? And oh, by the way, we already know, don't discontinue ICD therapy because they are still at risk for sudden death. So it's exciting because it gives us something new to discuss, to explore, but also it gives patients, and this is the most exciting thing, it gives patients hope. This whole concept of failure, Bob, and maybe this is what I want to end on, this whole concept of failure in the phrase heart failure is not obligatory. It is not obligatory. Many of us are stridently in favor of finding a way to take failure out of the discussion until we get into the advanced clinical syndromes. That very nomenclature probably has handicapped us for several decades. We have enough tools now where we can say that the failure in heart failure is no longer obligatory.
That is a great way to end, because the discussion that's been taking place, and in part led by you, is that words do matter in this case, and the words that we use to convey information to our patients really matter. And given that we have ways now, as you've nicely articulated, to prevent heart failure, to treat various syndromes of heart failure, and to think about the development of new therapies while at the same time applying known therapies, the future is really bright. And it's a big patient population, and your community that has really been working hard over the decades to deal with this group of patients deserves a lot of credit for sticking with it. I'm going to have you back, Clyde, to do some of the other topics that we've discussed, because I'm fascinated to hear about maybe one in particular. I'll have you come back in to discuss the SALT debate, which remains a big debate, and how we think about SALT versus the totality of nutrition is a whole other topic for heart failure prevention and treatment.
Yeah, I can't wait to have that conversation.
I want to thank my friend and colleague, Clyde Yancy, Professor in Chief of the Division of Cardiology at the Northwestern University Feinberg School of Medicine, where he's also the Vice Dean of Diversity. Clyde, thank you for joining us, and thank you, the listener, for spending some time with us to talk about heart failure.
Thanks, Bob.